millions of people.
Millions.
Millions.
Millions of people may have long COVID and not know it.
Imagine experiencing seemingly unrelated symptoms like fatigue and brain fog weeks after recovering from a virus.
I just never got better.
It's an enigma that could turn your body into a complex puzzle.
It hit every system in my body, the internal tremors and vibrations. This is me now.
Long COVID has forced me to only do the most important things.
It's ruined my life. I mean, it really has.
The disease is still part of the everyday lives of Americans who are battling long COVID.
Millions who survived their infection but now suffer from the troubling chronic condition of long COVID.
Welcome to the world of long COVID. Buckle up as we unravel the science behind this condition and why it's so essential to understand the brain and body connection. Long COVID is a condition affecting more than 65 million individuals worldwide and counting.
About 2-3 months later, when I wasn't getting better, I'm dealing with these doctors and they're not believing me.
It's literally ripped our lives apart.
I couldn't poop, I could hardly pee, I wanted to die.
But why does it persist? And why the seemingly random array of symptoms?
Feels like my brain is on fire, like it's being cooked on the daily.
When I tried to go back to work, I got physically sick.
Long COVID is a dual assailant, affecting both the brain and the various bodily systems, asking us to take a wider approach to solving this particular issue.
I don't think any organ is spared from the impact of long COVID.
The thoughts of suicide are something that I am hearing about every day when I'm talking with my patients, unfortunately.
Today, our scientific expedition unfolds, aiming at revealing the true nature of this mimic by probing into the neuropsychiatric dimensions of long COVID.
We need to kind of move beyond this notion of psychosomatic origin of disease and really look into the biological origin.
Learning as we go along about what are the right tests to do, what's the right approach with therapists, medicines.
Within the intricate realm of neuropsychiatry, the clues to effective treatment often lie, as we meticulously dissect the complex interplay between the brain and the body with scientific precision. So join me on this journey where the key to unraveling long COVID's mysteries lies in decoding its intricate disguise. So let's get started.
Study just out is giving new clues to identifying and possibly treating the mystery condition.
Experts say it is critical those suffering from long COVID keep pushing for answers. Studies are in progress to help determine the best treatments.
Most of those people afflicted by long COVID symptoms will be able to recover.
What do we need to know? Firstly, long COVID is a heterogeneous condition, akin to what syphilis was in the past, lupus, and anti-phospholipid syndrome. Second, there are multiple pathophysiological processes that play a part that lead to a cascade of multi-organ, multi-system involvement, presenting with the long COVID symptoms.
I've got a mild reduction of gas transfer and they're trying to rule out blood clots in my lungs. My liver, some enzymes went a little bit haywire and they think it might be liver inflammation.
Shortness of breath, tachycardia, extreme exhaustion.
Recognition of the pathophysiology is key to identifying which pharmacological approach to consider. So what are the range of symptoms of long COVID? Individuals describe fatigue. They describe it as battery flat, unable to do usual activities, trying to do more, often worsen symptoms for many. In some cases, this fatigue does not improve with rest. They often describe cognitive symptoms of brain fog.
You can't focus. You feel tired. Your memory has declined.
A fraction of the person I was before. Sort of like trying to trudge through neck-deep sludge, except mentally. You're tired, you're confused.
There is a phenomenon known as PESE, which is post-exercise symptom exacerbation. Very similar to what happens in chronic fatigue syndrome, PEM, post-exertional malaise. Here, individuals describe a crash or relapse of other symptoms, could be physical, cognitive, or emotional, or new symptoms following exertion. From a respiratory point of view, shortness of breath with physical activity can occur. Altered breathing, COVID squeeze, pressure in the chest. Some can describe excruciating chest pain.
All my chest pains started to come back and I just felt so unwell. I just felt so unwell and I've never felt right again since.
People may describe a sense of needing to work harder to take a breath or air hunger, where they describe they can't get enough air.
It was as soon as I got the shortness of breath, that was when I pretty much triggered the call to 111.
From a cardiovascular point of view, palpitations, dizziness, orthostatic tachycardia, HOTS, vertigo, loss of smell, phantosmia, a persistent disagreeable background smell. This is what I had. Unrefreshing sleep, exhaustion, exacerbation of fatigue and brain fog, vivid dreams or nightmares.
It's like being on a boat all the time. So when I stand, the floor is like this. So for me to walk straight is a struggle. There was a point where I literally needed to be lifted to go anywhere because I just couldn't get my balance.
Then we have pain, generalized, focal or regional pain, and this may progress to chronic pain.
My joints hurt all the time. That's something that people don't realize. It's just how much pain is involved in long COVID.
The pain in my foot is awful.
Because what we often find is that there are common pathophysiologies for 2, 3, or 4 symptoms that we can then target to improve all 4 of those. So in this video, I'm going to focus on the brain. I'm going to highlight why it's so important to understand the brain-body connection in long COVID and how the brain mediates a number of the symptoms that we see. So let's start off firstly with fatigue and brain fog. What is the pathophysiology? Now, fatigue and brain fog is not low mood. This has a completely different description where individuals may have significant cognitive impairment, they may have post-exertional malaise or symptom exacerbation, and there are 4 key pathophysiologies postulated. Firstly, impaired waste clearance, and this is due to involvement of the glymphatic system and CSF flow being hindered. Second, cerebral hypometabolism, a decreased perfusion of the frontal lobe, or in many cases, even generalized hypoperfusion. Then direct viral infection of the muscles can lead to fatigue and impact on dopamine metabolism, which is often a neglected part in the overall treatment. You see, inflammation reduces dopamine, and inflammation also results in increased noradrenergic tone in the amygdala circuit. Now, this converges into sympathetic overactivity. Sympathetic overactivity leads to vasoconstriction and therefore reduced perfusion overall, both in the periphery, so decreasing muscle perfusion, but also in the brain, reducing cerebral blood flow. The glymphatic system, which is the waste clearance system or the garbage truck of the brain, is another very important aspect to recognize. This is the metabolic waste clearance system in the brain, which is active during deep sleep, the non-REM slow sleep, and is deactivated during wakefulness. We know that insomnia is a core feature in long COVID, and therefore the glymphatic system clearance can be significantly affected. The reduced glymphatic system clearance and CSF flow restriction can lead to brain fog.
Word association is difficult. There's so many neurological issues that have come about because of long COVID.
My brain, they said, is working below capacity. And that's not how I was before. Like, this is just all stemming from long COVID.
How do we pick up clinically that the noradrenergic tone is elevated? The symptoms usually include anxiety states, heightened anxiety states, hyperarousal, irritability, mood swings.
Sometimes it feels like, for me anyway, I'm just dying on the inside.
And last fall, Amy actually tried to take her own life.
Thankfully, I didn't obviously carry it through. I'm still terrified that I did that.
So one of the strategies to consider in addressing brain fog is to improve glymphatic system clearance, and this requires bringing down noradrenergic tone. We also know that improving blood flow to the brain reduces mitochondrial dysfunction in the brain, as we know that they are very, very susceptible to hypoxia. Now, what happens in inflammation is that there is reduction of dopamine in the prefrontal cortex, and this happens due to a range of mechanisms: an increased uptake of dopamine, a direct reduction of the production of dopamine. And of course, when this happens, what we can get is brain fog, but the frontostriatal aspect is closely linked to the limbic system, which is the amygdala. usually what happens is the prefrontal cortex has a inhibitory effect on this arousal system. So what it's meant to do is to calm it down. And this is why individuals classically describe what's known as the wired fatigue.
All you want to do is sleep and you have no energy. It's like the energy's been like sucked out of you.
You feel like you're unmotivated, like you're not contributing.
So the wired aspect comes from the amygdala being overactivated. The fatigue, of course, comes from that frontal cortex function being impeded. Now, what's the link between dopamine and long COVID or chronic fatigue syndrome? Individuals with ADHD are more susceptible to developing long COVID and chronic fatigue syndrome. And there is evidence that individuals with ADHD have a greater severity of long COVID. Females are at greater risk due to amygdala hypersensitivity. A study also showed that the stimulant cohort of individuals who were taking stimulants in long COVID were less likely to utilize emergency department care or intensive care services than the unmedicated cohort, and had a significantly lower 30-day mortality. Next, we look at hyperarousal. The amygdala plays a very important role here. Hyperarousal significantly affects sleep. There is internal restlessness, and generally individuals find it difficult to control this restlessness. They describe racing thoughts, irritability that may fluctuate with fatigue at different times of the week, for example. Now, what are the mechanisms for hyperarousal and, of course, agitation when it's worse? This involves GABA dysfunction. We know that the virus can directly affect the GABA neurons. It also involves increases in noradrenaline and dopamine, because increased noradrenaline and dopamine in the mesolimbic pathway, which mediates what we call arousal, increases of these two neurotransmitters can significantly lead towards an agitation cascade. If you're a health professional, a psychiatrist, or a clinician looking to learn more about this topic on both long COVID, the neuropsychiatry of sleep, management of insomnia, we covered this in depth at the Academy by Psych-Scene. We've helped thousands and thousands of health practitioners reach the next level using our finest content developed with the help of top-class learning designers to maximize your learning efficiency. So we invite you to join us at the Academy to take advantage of all that cutting-edge practical knowledge that your textbook never taught you. So visit the link in the description to sign up today. We look at sleep. We know that sleep deprivation can result in elevation of a number of inflammatory mediators. Let's look at the role of inflammation and how it affects sleep. Now, cytokines that are released during inflammation have differential effects on sleep, both the circadian part and also the sleep structure. So it affects non-REM and REM sleep. Interleukin-6, interestingly, which induces hepcidin production in the liver, it actually decreases iron absorption in the intestines, leading to iron deficiency. And this can be associated with further worsening of fatigue, irritability, and result in clinical symptoms such as restless leg syndrome. Now, if obstructive sleep apnea is present, top of all of this, obstructive sleep apnea results in the production of HIF. HIF stands for hypoxia-inducible factor. What this does is further worsens not only the fatigue, but also inflammation. Let's look at the autonomic nervous system. We must recognize that the autonomic nervous system is activated when the amygdala is activated. Here we have two key parts, the sympathetic part and the parasympathetic part. We know that the vagal nerve plays a really important role here. The vagal system has afferents and efferents. So the afferents are inflammatory, which is from the gut to the brain. So these are afferents and are inflammatory. So here one can think about the gut-brain link, and inflammatory mediators can basically move from here to the brain, further worsening neuroinflammation. But the efferent, or efferent if you want to call it that way, it's only 20% of this vagal system. But what happens here is, imagine when the amygdala is firing so much that this sympathetic drive overtakes the parasympathetic drive. So it can overwhelm the vagal complex and therefore reduces the parasympathetic drive, which essentially has anti-inflammatory properties. Now, this can be heightened in individuals with pre-existing anxiety and trauma, as the amygdala has hypersensitivity as a vulnerability. Once again, the prefrontal cortex has to be optimally functioning to reduce this amygdala and autonomic nervous system dysfunction, what we call the top-down inhibition. But we know in long COVID, that's struggling as well. There are two types of POTS, and it's really important to recognize this. One is what we call partial dysautonomia, and this is due to the microfiber injury due to either nerve dysfunction, and this could be direct viral nerve infiltration, or due to increased risk of clotting, hypercoagulability. The second type of POTS is known as a central hyperadrenergic state, which is essentially a hypernoradrenergic state due to increased noradrenaline. We know that from the one end, we have hypovolemia, which is considered to underpin the cascade. So hypovolemia will lead to a sympathetic compensation. Why? Because when an individual with hypovolemia stands up, for example, the vascular tone needs to very quickly adapt to ensure perfusion to the brain. So what happens when there's hypovolemia here is there will be an increase in the sympathetic drive to maintain perfusion, and that results in vasoconstriction. So this vasoconstriction reduces cerebral blood flow and peripheral blood flow as well. So now you can imagine POTS itself can be associated with fatigue and the range of other symptoms that I talked about. But when blood flow in the muscles is also affected, then we have a range of other analgesic vasodilators that we talk about that further worsen the orthostatic stress and results in hypovolemia. Now, renin from the renal side is also affected, all of which basically move towards worsening the orthostatic intolerance as a cycle. Now, how do we link these release of vasodilators due to this vasoconstriction and impaired blood flow to the brain, to the muscles? How do we link that to symptoms? So these release of vasodilators can result in visceral pain, chronic fatigue, headache, muscular pain, dysmotility, flu-like symptoms, sore lymph nodes, and a range of other symptoms. But at the same time, you see what's happening is, remember the amygdala was active, hyperactivated. So therefore, we know that these symptoms that are occurring in the periphery due to hypovolemia will be perceived by the brain as well. And we know that the key parts of the brain that perceives this, the interoceptive area, is the insula. So let's now look at how the brain reacts to this and how this cascade then worsens. So the key parts of the brain that are involved are the anterior cingulate cortex. This is for behavioral arousal or behavioral amplification. Next, we have the insula. This is the seat of interoception. What happens here is that there is somatic hypervigilance. What I mean by that is that individuals really now focusing on these symptoms excessively, understandably, because they're experiencing a distress, but at the same time want to relieve that distress. Next, we have the hypothalamus. The hypothalamus is responsible for the stress response through the release of corticotropin releasing factor, basically which will move forward, act on the adrenals, and release cortisol to reduce this stress response. But here again, there are abnormalities. And finally, we have area of the brain known as PAG, P-A-G, which is a periaqueductal gray. Now, this part of the brain is involved both in trauma responses, for example, in PTSD, but also in pain modulation. But this interoceptive abnormality involving the 5 areas of the brain results in additional symptoms such as a worsening of visceral pain, chronic pain conditions, dizziness, worsening of fatigue. So therefore, when we think about managing POTS, on the one hand, it can be managed through increasing the volume, and this is where, say, fludrocortisone, etc., is prescribed, which increases sympathetic tone in individuals with the partial dysautonomia, because if we increase the sympathetic tone in the central hyperadrenergic type, then they're more likely to worsen because they've already got excessive noradrenergic activity. We don't want extra adrenergic activity. In the latter, which is the central hyperadrenergic state, reduction of noradrenergic tone is essentially what will be beneficial, because what that does is it will promote blood flow because vasodilatation occurs. In some cases, strengthening of the prefrontal cortex is also required, and this makes it easier then to consider the alpha-2 agonist or an alpha-1 antagonist such as prazosin. Hence, understanding and differentiating the two is needed, which is why when one looks at the literature with POTS, one will see different approaches, different recommendations. For example, POTS with fatigue, POTS with mast cell activation, POTS with brain fog. They have different medication options, but they're linked approaches. We're going to touch on mast cell activation. Mast cells are part of the innate immune system. They're ubiquitous across peripheral nerves, brain, and they're in very close connection to vessels and nerves. Now, mast cell activation releases histamine, And that's often one of the first things that comes to mind when we think about mast cells. But it's important to recognize that it also releases a number of other factors: serotonin, prostaglandin, tryptase, heparin, etc., all of which converge, leading to vasodilatation, which can lead to pooling and then further worsens POTS. It's also important to recognize that mast cells, because they're in close proximity to nerves and endothelium, they also play an important part in pain modulation. Next, we have endothelial dysfunction. We know that the ACE2 receptor situated on endothelium, the virus uses that ACE2 receptor to enter. And here, of course, endothelial dysfunction can worsen a range of these symptoms. Fatigue, brain fog results in hypoperfusion, results in vasoconstriction. Endothelial dysfunction may be more present in conditions such as Ehlers-Danlos syndrome. We've also got to take into account hypercoagulability, which is increased clotting risk, because in long COVID, as I mentioned, the possibility of anti-phospholipid antibodies may be there. There is evidence of microclots, for example. So increased risk of clots is something that should be taken into account in the overall management as well. Then we have pain. Now in pain, ACE2 receptors are highly expressed on dopamine neurons. So what this is telling us is the virus can directly affect dopamine neurons and result in destruction. But there is another issue that happens, which is involvement of dopa decarboxylase, the enzyme that converts dopa to dopamine. And so therefore what we get is an altered dopamine metabolism, something we've recognized earlier as well. So multiple pathways are pointing towards dopamine dysfunction, linking to a range of symptoms. And furthermore, noradrenaline as well, linking to a range of symptoms.
Leg aches, and then I get headaches, like pains in my eyes. I don't feel like myself anymore.
Finally, from an organ perspective, we have a range of other organs involved: lungs, cardiac, endocrine, etc. The key here is to liaise with the specialists involved in the care, or in long COVID clinics, for example, and consider an overall formulation incorporating what I've gone through, because often what I find is that the periphery is being addressed, but the brain is completely forgotten in the pathogenesis of long COVID. Many a time addressing these symptoms can provide significant relief to patients. So therefore, my message really here is treatment should be multi-pronged based on the underlying pathophysiology. There are many approaches postulated. More recently, for example, to highlight even further why taking into account the neuropsychiatry becomes important, is that there was a paper published 2022 on persistent brainstem dysfunction in long COVID. So brainstem is essentially pons, medulla, all the way down to the spinal cord. So you can think about this pathway down here. We have, if you think about it, the dorsal raphe nucleus, serotonin, locus ceruleus, the noradrenergic neurons, VTA, ventral tegmental area, where you have dopamine neurons, substantia nigra, where you have dopamine neurons, which are involved in Parkinson's, for example. You have the ascending reticular activating system for sleep. We have the vagus, the nucleus tractus solitarius, and a range of other areas that play an important role in the pathophysiology. But I guess I'm trying to highlight the role of serotonin, noradrenaline, and dopamine, which is often neglected here. And the reason why I mention that is in most severe cases, a single agent may not be able to address all issues. For example, I've seen a range of agents being discussed in long COVID: fluvoxamine, famotidine, loratadine, melatonin, quercetin, milk thistle, vitamins, nattokinase, naltrexone, so many different agents. Now, each of these have a pathophysiology, a reason why they're being prescribed. But what's important to question and ask is, in the more extreme phases, now many of these I'm sure benefit people, which is why we'll often find comments saying, this helped or that helped. What we've got to recognize is, if it helps, great. Point is, what happens when it doesn't help? That's where we need to start thinking about, or outside the box. We've got to start thinking about, can quercetin, for example, address the more severe end of the spectrum of hyperarousal, sleep, pain, mast cell activation, etc.? Can nattokinase on its own do that? Can melatonin? Melatonin may improve sleep to a certain extent, but once noradrenaline's involved, melatonin's very unlikely to result in calming down that amygdala. Then we have agents such as alpha-2 agonists or alpha-1 antagonists that act on the amygdala and bring down the hyperadrenergic state. For example, midodrine, which is often prescribed by physicians, is an alpha-1 agonist for POTS. But If hyperarousal is present, alpha-1 agonism can actually worsen the overall picture because there is already excessive alpha-adrenergic activity. We talked about how beta blockers may worsen POTS or mast cell activation by leading to excessive degranulation. Antipsychotics are useful to significantly reduce amygdala hyperactivity, but low doses often make the difference. So in summary, long COVID seems to be the new great mimic of our age. The key message is to not forget the brain in the overall picture in the management of long COVID. It's also important to recognize the role of neuropsychiatry in the overall picture, as many of these symptoms are mediated through the brain. So I hope that this has given you an overall understanding of long COVID from a neuropsychiatric perspective. I look forward to seeing you in another video soon. If you like this video, make sure you hit the like button and of course leave any comments. Let us know what's worked for you. Let us know if you've got any questions. So until next time, stay safe. Bye-bye.